collaboration of all of you. And we start with one case of a male, 20 years old, that fall from the stairs with occipital impact, severe headache and vomiting. So we did imaging, and you have seen this case already during the lecture, so it should not be very difficult to take. So I will ask the collaboration from the first row here, or you have the microphone and the pointer, and just point to us what are the positive findings that you see here. Work. Thank you.
So in the right occipital region, there is a lens-shaped area of hyperdensity with some air bubbles within and irregularity of the overlying bone. It does not seem to cross midline, but it does cross down into the posterior fossa, and is in keeping with a epidural hematoma with an overlying fracture.
Very good. So would you think that we should be concerned regarding this patient on the evolution? Do we have signs that are actually worrisome for us?
Yes, because it's an open fracture.
Yes.
For once. So it needs a different treatment. It has the depression. Because it's an arterial, most likely an arterial bleed, it can rapidly increase, and so it needs neurosurgical input immediately. And about the mass effect that it also has a little bit of a mass effect. The fourth ventricle is asymmetrical, and as it goes into the posterior fossa, it's kind of more likely even to cause bigger compression of structures and intracranial hypertension.
So, very good. So, everything was said. So, if we have infratentorial, supratentorial, haemorrhagic extraaxial lesion, it has to be epidural. Because the subdural will continue to the tentorium and will not pass to the infratentorial to the super or vice versa. The other thing that was pointed out is that this is caused mostly from a rupture of a dural artery that is at the surface, and we have signs that actually this is an acute hemorrhage. We have blood that has already it's not hyper dense, hyperattenuation, so this patient is in active bleeding. So it should we need to be very careful with this patient. This is like what we have in real life. So if you actually want to see the images of the patient and you want to be sure that it's going from the upper compartment to the lower compartment, just do your MPRs, and you see even if you don't do volumetric acquisition, you can actually have no doubts here that it's an epidural hematoma. And can we see the fracture here? So it was already pointed out, so we are looking into the bone.
Yes, I can see a fracture line on the right occipital side, and it's not a sutura. It's not it's a real fracture without no step and no impression.
Any pitfalls on the imaging that we should be alert to having a fracture? Additionally, what do you think about where is this coming from? This is air. So whenever we have air inside the intracranial cavity, we should be suspecting of a fracture, even if we don't see it. Most commonly they are located at the skull base, and we may need to do thinner acquisition. Here we have the fracture of this case. Okay, so we go to another case. So this patient was found unconscious at the street, a young male, and there is a suspicion that he's being victim of aggression, and this is the initial CT. So if you want to continue, just pointed out the positive findings that we have here?
There is on the left side a hyperdense lesion, 2 lesions. That's intracranial bleeding in the acute stage, and around hypo-intense edema of the brain, so it is an haemorrhagic contusion of the brain tissue.
Are there more? So we are going to see here that we have hemorrhage in different compartments. So we have brain hemorrhage, so you have one there, another one here.
And
so typically of the temporal lobe, so where it impacts the bone at the middle cranial fossa and at the sphenoid ridge, more that you see.
There's also on the, I think on the right side, a little above the tegment tympani.
Here? And more. So we are looking at trauma. There are specific areas that we should look. So middle cranial fossa, temporal lobes, and what else? Who wants to help? Still on the intraaxial, still on the brain hemorrhage. Where? Bilateral frontal. This is very typical. This is where we are going to have also the brain lesions to the impact of the gyrus rectus and orbital frontal gyrus into the floor of the anterior fossa. Okay. So these are not like this one especially. They are contusions that have hemorrhage and have also edema associated. Okay, so we have seen the compartment of the brain. Do we have other areas of bleeding? Infratentorial, supratentorial. What is happening here? So you have a subdural hematoma there, right?
Also a bit of subdural bleeding along the posterior falx and along
Correct. Correct. So you see, this is more hyperdense than it should be. This is the posterior 1/3 of the falx, and it continues over the tentorium. And you need to understand that this area here, this is blood above the tentorium.
Is there also a slight subarachnoid hemorrhaging at the left occipital lobe? On the last image, left side area.
Probably. We have also superficial subarachnoid hemorrhage and also a tiny component of blood in the interpeduncular cistern. Very good. So we have seen on the different locations of hemorrhage. And continue to see, you see that there is extensive subdural hematoma. Continuing there, you have the brain contusions, and you see that there is a thin layer of blood over the falx, and you have some subarachnoid foci of bleeding on the convexity and also here. So you have different locations for the blood. Continue the images, and again the subdural hematoma that you see here, and the contusions that were actually very severe. And what about this? This would be also subarachnoid hemorrhage on the superficial location, as here and there. So, and now, what can we tell about the bone windowing of this patient? Do we see anything that actually is worrisome for the patient? So let me help you. There are a couple of things that we should look. Very good. So let's go back, because this was here. Maybe it's inflammatory. We don't know. What do you think about the density here? It's blood. So this comes to a different level. So probably we are going to have a skull base associated fracture. Okay? And what is our concern when we look at skull base fractures are the important structures that actually pass nearby. And this would be what? Carotid arteries. Okay? And the carotid at the cavernous sinus. Okay? But we have feeling of another cavity, not only the sinus. What is happening here? So it could be, again, could be inflammatory, but in a trauma patient, we are looking and we have the middle ear that is filled. So we need to look careful to this. And we are going to pass this. Another point that is interesting is to look at the fractures. Sometimes on the axial views, we don't see it very well. But when we do the 3D reformation, it becomes obvious, especially when we are looking into children that have not closed the sutures, where the fractures are. Can you tell where is the fracture of this patient? So where it is. You have an extensive fracture there. Okay? If we go back, now, where is it? Very difficult to see. Okay, so this is a pitfall on trauma patients, always to do the 3D and to look at the fractures. And if you think that the axial slice will be parallel to the fracture, you are not going to see it on the axial view. But we are concerned about the middle ear, so actually the fracture was there, and that there was a filling, and we need to look at it, and actually if we do the reformation, we see the fracture, temporal bone fracture, there, also with external auditory canal fracture, meaning that it was a very high impact lesion. Very good. So these are some pitfalls on the trauma patients. So now we are going, not a traumatic case, so a female, 60 years old, and we have admission with a thunderclap headache, complete third nerve palsy, and the patient was hypertensive, she smoked, and was obese. So I'm not going to show you the case, but with this clinical information, what are you suspecting?
So many underlying contexts for this patient, regarding to hypertension, regarding to obesity, or something like that.
But look at the admission. Thunderclap headache. This is like the worst headache that I ever experienced in my life. When your patient says that, what do we think? Perfect. As a bleeding, most probably a subarachnoid bleeding, because it was the patient has no neurological deficit, but he has a strong headache. So you are thinking on that. You may think on venous thrombosis. There are a couple of other syndromes that are more rare. And then we have complete third nerve palsy. And this we need to know some anatomy. So this pointed out left PCOM aneurysm. Has to be it. Okay? No other possibility. This is like... So do you have the subarachnoid hemorrhage and you have your PCOM aneurysm? Well, do we have a hemorrhage? Yeah, so we have some hemorrhagic lesion here, right? Some edema. It goes well into the surface. I don't like this tentorium. well, old people may have a thickened tentorium, but this looks like blood here. Okay? Not probably a massive subarachnoid hemorrhage, but something has bled, and it's outside of the if it was an intraaxial bleeding, it was strange to go to the subdural space. So, what we do now? CTA. Good. So you have the CTA. Oops, sorry. It helped. Where is it? Can you point out?
And arising from
here?
Probably at the origin of the ACOM on the left, I would think. Or
The PCOM.
PCOM on the left.
Posterior communicating artery. So reviewing the anatomy. So we are looking into axial views. So these are the two internal carotid arteries, and we go up. And we have the middle cerebral artery on one side, the middle cerebral artery on the other side, the A1 of the anterior cerebral artery, the A1 of the anterior cerebral artery, and this will be the basilar and the posterior cerebral arteries. So we have something here that is in continuity to that hemorrhagic area that we have seen that should not have been there. Okay? And it's actually here. So, in continuity to the supraclinal segment of the internal carotid artery. This is the normal one, and this is the abnormal one. So, M1, A1, so it's below bifurcation of ICA, and you have contrast here. So, this is an aneurysm, right? Is the only aneurysm of the patient? Where is the other one? ACOM. You have another aneurysm there. Now we have two. Which one is the symptomatic? The PCOM, because you have third nerve cranial palsy. No doubts about it. Okay? So this is the DSA of the aneurysm. Okay? And these are the things that actually you need to report when you do a CTA. So location and orientation. What can you say? Location is the PCOM, supraclinal segment at the PCOM. This is the PCOM, right? If this is the PCOM, this vessel here above will be what? Anterior choroidal. Good? So, orientation. Simple. It's pointing out, it's pointing posteriorly and inferiorly. Neck, sac ratio. The neck is this area, the area where it attached to the artery. The size of the sac is this one. You cross it. It's completely different if you have a very narrow neck or if you have a large neck. Okay? And it's an angio, but the CTA will give you the same information. Another thing that you need to report is there any vessel coming from the sac of the aneurysm? Because if it's coming from the sac of the aneurysm, if you are going to put coils inside, you're going to block that artery. Is there any artery coming from the neck or the sac of the aneurysm? So this is an internal carotid artery, goes here, 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 ACOM, MCA. Where is this coming? The base. Yeah, we don't know, but here we see it very well. So the neck is there, and at the base of the neck, we have this. Calcification, we don't see calcification, and the vessel is not spastic. There is no reduced lumen. Okay, so the treatment here, you have two options, or you operate the patient, or embolize the patient, and in this case, we are here with the catheter, here inside, a balloon at the neck, so everything we put inside keeps inside and does not go inside the artery. And you see the balloon inflated. This is the aneurysm. These are the coils that you use to treat. And this is the final result where you still have the PCOM there open. Okay? Very good. So another patient, 58 years old male, severe headache, left hemiplegia, hypertension, under treatment. And you have the microphone on the second row. Go ahead, go ahead. Couldn't be easier. I would take the microphone on this case. See? Smart choice. So, hypertensive male, normal CT?
No,
not
normal.
Good.
This looks like high attenuation in the basal ganglia on the right side. A typical location for hypertensive bleed.
Okay, very good. So we have actually probably no doubts based on the clinical history on the location of this hematoma that this is a hypertensive hematoma. In most of the places we don't do additional investigation unless, with the exception just for the follow-up. So what are actually the prognosis factors associated with an intracranial bleeding that we need to report or exclude? So we need to say the size of the...
It has mass effect.
The mass effect. And does it has mass effect? Yes, you have middle side shift. You see, you have some brain herniation. Another thing that is important is there actually intraventricular bleeding? No. Because if it was there is intraventricular bleeding, the complication that we can have is what? Hydrocephalus. Very good. Okay? So this is one of the scores that we use to evaluate the prognosis of the patients. And as you see, the volume is important, the presence of intraventricular hemorrhage is important, and the location is also important. Okay. 87 years old male, transient right limb paresthesias, focal weakness and dysphagia, had a previous stroke with hemianopsia homonymous. And this is the CT. What are the positive findings?
There is a hypodense lesion on the left.
Here?
Oh, yeah.
Does this look like an acute lesion?
No.
No. Do we see anything that could be acute in this patient? Anybody wants to help? Very good. So we have a very small bleeding there. Probably, or it's cortical, or it's subarachnoid. Okay. So we are. Does this look like a rupture of a brain aneurysm? No. So we are in a different type of differential diagnosis, being the cortical, the spontaneous cortical subarachnoid hemorrhage. So he pointed out already, your colleague, amyloid angiopathy, especially in the elderly patients. But we can have other situations, like cavernoma is rare, cortical vein thrombosis, vasculitis, reversible vasoconstriction syndrome, dural arteriovenous fistula that can be very superficial, okay? And a very distal aneurysms. Distal aneurysms are not the common ones, sacral Barry aneurysms at the circle of Willis. These peripheral aneurysms are commonly associated with what? Inflammation or infection, so myocardial aneurysms, okay? So these are a different type of differential diagnosis. So we now need MR to help us. And now we have the MR. And can we actually, with the things that we find here, help in the differential diagnosis? See that it's very difficult to see the acute bleeding on the T2 because on the T2, if you remember, the acute blood would be, the oxyhemoglobin would be hyperintense. So you needed a flare imaging. But we have other findings. So you had the lesion that we have seen on the CT, and you see that this is hemosiderin. So this lesion had hemorrhagic components. Do you see anything else? Yeah. Very good. So hemosiderin. So signs of previous bleedings at the subarachnoid space that would help us to make the differential diagnosis and actually to point it out on the T2 star, and if you have done SWI would be even more extensive than to actually to put the diagnosis of amyloid angiopathy. Right? Good. And if we are not sure, we wait 2 years after and the patient had another bleeding. Okay? And this is the natural history of amyloid angiopathy. Okay, the Boston criteria that I recommend you to look at out to see the features associated with CAA. Okay, another patient, 82 years old, female. She had a reduced vision since 2 weeks. At neurological examination, actually is an homonymous hemianopia. The patient has hypertension and coronary heart disease. And this is the CT. What are we seeing here?
This hypodense lesion in the left frontal area.
Right here. Does this explains the symptoms of the patient?
Not really.
Hemianopsia homonyma. So this would be a lesion where?
Occipital.
Occipital. Okay? So the patient has maybe an infarction here, because it goes into the cortical area, have small vessel white matter disease, as you see here. And what is happening on the occipital lobe?
There is this hyper intense changes, I don't know, in the right occipital
So this one
area.
explains.
And this would explain the symptoms.
It's coming from 2 weeks. So the patient has this for 2 weeks. What could this be?
Hemorrhagic transformation.
Very good. Of a posterior cerebral artery infarction. Very good. So, and this was the case. Let's look at this one. 73 years old, female, right hemiparesis aphasia, hypertension, fibrillation on comodines. So the patient is anticoagulated. Okay, I'm going, because of the sake of time, I'm going to just to show you the positive findings, and we have hyperdense MCA here. Patient went for treatment, and what on the follow-up, what do we have? Yeah, this is blood, actually. So you see the infarct area here, some edema also, and a hematoma that is more than half of the size of the initial lesion. What is this? Again, the same thing, hemorrhagic transformation. Okay, so this is how you classify hemorrhagic transformation. This is the ECAS classification on petechial infarction, and this was the first one with more confluent petechial, because you see it on the CT and it was confluent, and hemorrhage with mass effect. In this case, it was a PH2 because it was more than 30%. So the ECAS is actually the classification you use for hemorrhagic transformation. Okay, 34 years old, male, with seizures, presentation, had a history of thyroid cancer that was operated 1 year ago. And this is the clinical presentation, and this is the MR. So you have the T1 and the T2 images. You have to move fast to see more cases. Almost running out of time. Okay, so we have a lesion that explains the symptoms. So this is the motor strip here, the frontal. So here it is, and he has a hemiparesis because he has a lesion there. So the lesion is heterogeneous, right? Associated with edema. Has high and low T1, high and low T2 signal. Okay? Does this look like a lobar hematoma? No. Okay, so we have an underlying hemorrhagic lesion here. Want to see anything else? Contrast, not really very, we could not depict contrast enhancement. It's very difficult in the phase that you have a hyperintense T1 lesion. I give you the SWI. So now we don't have one. How many lesions we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay? So now we are in the differential diagnosis of multiple small foci that we have seen, like the microbleeds, right? But this is a young patient, not hypertensive. Could be. That is good. Could be thyroid cancer full of metastases. Although it was actually strange that this one and this one had no edema. But the symptomatic one had. The edema just tells us, in this particular disease, that the lesion has changed in size. And the change in size had associated with edema. But it has many other dot. Okay, vasculitis. Things that give you this type of pictures. Could be diffuse axonal injury, which is not the case, because this is not diffuse axonal injury. Metastasis with microbleeding metastasis. Could be. More. Multiple cavernomas. Okay? Young patient, multiple lesions, and actually this was the case with multiple cavernomas. This patient was operated on this. Okay. I think we have actually reached the time, and thank you very much for your participation.